All right, so negative and positive feedback loops, this should look a little bit familiar to you. We did cover this, but this is everything to do with the endocrine system as well. So negative feedback loop, again, is our most common type of feedback loop. Positive is far less common, and really the only good example in the body of a positive feedback loop is childbirth. So as you're having contractions, the baby is pushing on the head of the cervix. You're releasing additional oxytocin, which is stimulating further contractions until you tip the balance and you expel the baby, and then the cycle stops. That's a positive feedback loop. Negative feedback loop is precisely the other way. Something happens, and then in response, you have a reverse response that attempts to stop it or slow it down and bring it back under control. So a classic example of this is going to be blood sugar or thyroid. If your thyroid hormones start to drop a little bit low, well, guess what? Your hypothalamus is going to say, hey, we should maybe consider picking up the pace here. It's going to release your thyroid releasing hormone, which is going to go to the pituitary and say, let's stimulate the thyroid gland, let's release TSH. The TSH is going to go down to the thyroid gland and actually cause the thyroid gland, if it's functioning properly, to release additional T4. As T4 rises, we're not going to need the signals going back up to the hypothalamus, and we're going to stop releasing the TRH up at the top, which means that we're not going to get the TSH, which means that we're not going to get as much T4. So you can see that that's kind of a negative feedback loop there. So hormonal dysfunction. When we talk about dysfunction, we're essentially talking about a couple of problems. Hypersecretion, hyposecretion, so too much or not enough, or extraglandular disorders where for some reason you are over or under responsive to that hormone. So either you're making too much, you're making too little, or you're responding weirdly to it. So hypersecretion, we could be looking at things like tumors, endocrine neoplasia, hyperplasia, too much of the tissue. And this is going to include things like hyperthyroidism, acromegaly, too much of your growth hormone, thyrotoxicosis, Cushing's disease, where you have too much cortisol, precocious puberty, where you have too much of your sex hormones at an early age. And obviously, hyposecretion is going to be the opposite side. We could have gland destruction through autoimmune diseases. We could have hypotension. We could have shock. And this is going to be things like diabetes insipidus, hypothyroidism, adrenal insufficiencies, Addison's, etc. So glycemic control is a classic example of a negative feedback loop. Insulin tells our cells that it needs to uptake glucose. That's really what insulin does, is it says, take the sugar out of the blood, move it into the cell, and use it. When it does that, it is decreasing the level of blood glucose. We're increasing the level of intracellular glucose, and we're decreasing the level of extracellular glucose. Glucagon has a very different effect. It causes your blood sugar to rise, but what it's actually doing is it's going into the liver and saying, hey, we should break down some of our stored energy, and we should release this back into circulation. So it's breaking down glycogen, which is a stored form of energy or glucose, in order to increase our blood sugar. So obviously we want to keep our blood sugar within a very narrow kind of therapeutic range, usually somewhere in the range of about 60 to 100. It's considered hyperglycemia diagnostically if we have a fasting of greater than 100 or greater than 140 after a meal, and pre-diabetes if we're fasting generally in the range of 100 to 125. You will notice that over the years that the levels for acceptable blood sugars have changed dramatically. When I first went into practice, we were like, oh, anything under 200 is fine, you know. We're not really saying that anymore. So now it's like, it used to be anything under 120 was a normal fasting. Well, now it's anything under 100 is a normal fasting. So things do keep changing, because what they're finding as they're doing their long-term studies is that even low levels of chronically elevated blood sugar can lead to microvascular changes, which are going to be associated with things like heart disease and chronic end organ damage. So the parameters keep getting tighter and tighter for glycemic control. So diabetes, again, if you have a fasting blood sugar greater than 125 on 2 separate tests, that is a classification of diabetes. any random blood sugar of greater than 200 is generally considered diabetes unless it's in some sort of a bizarre illness stress state where maybe you dumped a whole bunch of sugar into somebody and they couldn't respond fast enough. But in general, if you're just taking a random blood sugar and you get greater than 200, that's going to be a classification of diabetes. Hemoglobin A1C greater than 6.5 will give you a classification of diabetes. So if you take a random sugar on someone and you don't get an elevated sugar at that time, but they have a hemoglobin A1C of 6.5 or greater, that is a classification for diabetes. Hypoglycemia on the other end of the spectrum is generally going to be blood sugar less than 50. And again, this is just a picture on the right-hand side of the negative feedback loop from the pancreas all as to how it kind of works back and forth in order to regulate our blood sugar. So when we talk about the pancreas, you often hear the term the islets of Langerhans. We're talking about beta cells a lot because beta cells are the cells that release insulin. Well, we have other cells in the pancreas, alpha cells, A, beta cells, B, delta cells, D. Someone wasn't feeling very creative when they named these. They just said cell A, cell B, cell C, cell D. And these kind of cluster together into little islands within the pancreas, small little communities that do things. Each of these cells within the pancreas releases a different hormone. So our alpha cells, what is going to release our glucagon. That's the hormone that is going to increase our blood sugar. Our beta cell is going to release both insulin and amylin, which is going to effectively decrease the circulating blood sugar. Amylin is going to assist insulin by slowing intestinal absorption of glucose. So it's kind of an aid to insulin. It doesn't have the same effect as insulin. It's just kind of a helper type of situation. The little tiny purple picture down in the left corner is just simply a slide of what these islets of Langerhans actually look like in the pancreas, which is kind of interesting. They really do look like the picture. So pancreatic hormones are the key to diabetes mellitus, and we're going to have a presentation on both type 1 diabetes and type 2 diabetes. I'll apologize if I'm tromping on your ground a little bit, but I will just daintily cover this. But it's good to have reinforcement, and I will kind of try and keep it a little bit superficial here, so I'm not stealing everything. So pancreatic hormones, glucagon. So our alpha cells, when glucose is low, acts to increase the serum glucose. Insulin from our beta cells. This is our major building hormone throughout the body, and it's released for a rise in blood sugar above 100. So when your sugars go above 100, you're going to be releasing insulin. It's going to rise rapidly and then return to normal in about 2 to 3 hours. Amylin, also from the beta cells, is going to decrease the serum glucose by reducing gut absorption of glucose, so we don't absorb our glucose as well, and then inhibiting the production of glucagon, again, which causes a rise in blood sugar. So it's going to inhibit glucagon. Somatostatin, growth hormone inhibiting hormone, is released from the delta cells in the pancreas. And it's also released from the hypothalamus and the pituitary. So it's released in multiple different places. And it is an inhibiting hormone, which inhibits glucagon and insulin secretion. So basically, hey, whoa, back it off. So you can see how it's part of this negative feedback loop. Insulin, action on the cells. Obviously increases glucose uptake, moving sugar out of the blood and inside the cell. It is going to increase glycogen formation. So if you have too much sugar, it says, what do we do with all the sugar? We can only move so much inside the cell. The cell is now overloaded. We've got to find a place to start storing this. We're going to pack it up into neat little particles, and we're going to package it out into glycogen, and we're going to deposit it. It decreases what's called gluconeogenesis. Neo always stands for new. So the new production of glucose, it decreases that. It's going to increase protein synthesis, which is why it's considered a building hormone. It helps your body to make additional proteins and link peptides together. It also increases fatty deposits, which means that it decreases the free fatty acids in the blood, but it does that by causing you to deposit it somewhere. So we're going to get this out of the blood, and we're going to put it down somewhere. So you can start to see why people with diabetes, when their sugar is high, they develop accelerated atherosclerosis because they have to put those free fatty acids down somewhere, so they're going to lay it down in the arteries. Decreased lipolysis, so we're breaking down less of our fat for stored energy. So when we give people insulin, we're going to help them start to clear ketones from their blood. We're going to increase the potassium uptake into the cells. So again, why do we treat people with hyperkalemia with insulin? Because we're moving potassium into the cells. And therefore, it's going to decrease our blood potassium. This is just a little picture of insulin and insulin receptors. It's kind of that lumpy, bluish looking protein molecule that comes over, and it's going to bind to a receptor on the membrane, activates a molecule called tyrosine kinase. This is a signaling molecule that is going to initiate some very complex intracellular pathways. A lot of times we think of insulin as just being blood sugar. It is releasing like 40 different pathways. We're not going to go into all of those because you would hate me if we did, but it is a fascinating thing to actually look, and I'll show you on the next page a picture of some of the pathways that it is triggering. The big one is GLUT4, and you've probably heard this in our prior lectures. GLUT4 is a transport molecule that when insulin activates tyrosine kinase, it signals to this GLUT4 transporter, hey, go over to the cell membrane and pick up some sugar and bring it into the cell. There's a package delivery outside, essentially. You want to go pick that up and bring it on in. When GLUT4 gets to the cell membrane, it kind of pushes its way through the membrane and it starts to grab sugar molecules and pulls it inside the cell. This then allows us to go through our process of metabolism and storage, which is going to include things like glycolysis, our Krebs cycle, breaking it down, making ATP, and making proteins. So insulin resistance, we'll cover a little bit of that, and I'm hoping that our type 2 diabetes presentation will tap into that, because that's really what type 2 diabetes is. Insulin resistance is that you have changed, over time, you have too much insulin in your body. So you're flooding the inside of cells with too much glucose. So your blood sugar outside the cell is high, and you're trying to manage that, so you start flooding the inside of the cell with too much glucose. Well, the cell doesn't really like that. The cell starts getting a little bit protective of itself, and it says, well, hey, if you're going to keep jamming all this stuff in my space, I'm going to make it harder for you to do that, and I'm going to downregulate some of my receptors. So what happens is that over time, you become less sensitive to the effects of insulin because you have chronically slightly elevated blood sugar levels and chronically elevated levels of insulin. So you're just going to say, like, I'm not responding to that as much because the cell's got to protect itself. So insulin receptor pathways, this is just the picture I was mentioning. Here's insulin shows up, and you can see that it's initiating this entire cascade of events. Comes in, and it has the insulin receptor substrate proteins, and then it's going to go in and hook up into all these different pathways, and it's going to affect how our ions move. It's going to affect our metabolism. It's going to affect how we make proteins, how we do transcription, whether or not the cell grows, whether we break down fats, and whether or not we make storage kind of sugar, glucogenesis. Don't memorize this slide. This is just informational. All right, review. Energy production. So you may remember from early on in our cellular process that we talked about glycolysis, gluconeogenesis, and glucogenolysis. I broke these up into blue and red words just to help you look at it in terms of what the components of the words are, because they will actually tell you what it does. So glycolysis, lysis always means to cut or to break apart. So we're breaking apart glucose. We're breaking it down with enzymes. We start out in the Krebs cycle. We're getting byproducts of pyruvic acid and water and carbon dioxide. And then we're going on into our electron transport chain and phosphorylation, and we're making all our ATP. So that's glycolysis, the process of breaking down glucose and turning it into ATP and getting some cellular metabolites and waste products. Gluconeogenesis is a completely different process. It's a building up type of process. So we are making glucose from non-carbohydrate molecules. So we might take something like lactate or glycerol, And we might build it into a glucose-like substance that we can then realistically use for energy to fuel our ATP kind of processes. So that's the genesis, creation. Okay, so gluconeo, glucose, new glucose, creation. And then we have our glycogenolysis, and glycogen, again, is the stored version of glucose. So we create glucose into a completely different package. We store it as glycogen in our liver and our muscles, and then when we need to access it, we're in a fasting state and our blood sugar starts to drop. We release some glucagon and we say, hey, we're going to go grab those stores, we're going to break them apart, and we're going to dump them back into circulation so that we can use them in the form of glucose again. So that is our glycogenolysis. We're breaking it apart and putting it back into circulation. Hemoglobin A1C, so from a clinical perspective, a lot of times we just tend to think blood sugar, what's your blood sugar, is it within range, and what's your hemoglobin A1C? Well, what is a hemoglobin A1C? So it's very interesting. Hemoglobin A1C is not really a direct measure of blood sugar at all. When you have high levels of blood sugar throughout the body, you're actually doing a process called glycolylating your hemoglobin molecules. Hemoglobin on the red blood cells, which is the molecule that is transporting oxygen. What we actually do is we modify one of the little ends of that hemoglobin molecule, and it kind of attaches a little piece, and it's called glycolylating the hemoglobin. So when you have chronically high blood sugar levels, what you're actually doing is you're modifying your hemoglobin in such a way that it's leaving a footprint of the fact that you had high blood sugar. So when you're measuring your hemoglobin A1C, it's actually kind of a proxy measure of what is your average blood sugar over time. And the reason we do a hemoglobin A1C over a 3-month period is because guess what? The life of our red blood cell is about 4 months. So we're saying that that red blood cell is exposed to kind of this average condition over time. How much of the hemoglobin in that red blood cell has been glycolylated? We measure it as a percentage. So if 6% of the hemoglobin in your red blood cell has been glycolylated over time, then we know that on average, your blood sugar has been a such and such approximate range. And in this case, it would be hyperglycemic. So essentially, all we're doing is we're forming a little sugar to hemoglobin linkage. And measuring it over a 3-month span. For diabetes, an A1C test that is less than 5.7, a person does not have diabetes. Once we start getting over 5.7% of the hemoglobin being glycolylated, then we do have high blood sugar. And once we get to 6.5%, it actually is a classification of diabetes. Gestational diabetes may run in the range of 5.7 to 6.4%. It is an indicator that that person may very well, at some subsequent point in time, develop diabetes. It shows that when their body is under a stressful situation, strained, or needing to produce more sugar, that it's not responding in a normal fashion, and the likelihood is that over time and with age, that that's going to show up again. So if you do have someone who has gestational diabetes, you should talk to them and say, you know, the likelihood is that down the road, you may have an issue with diabetes, and there's certain things that we can do now to try and prevent or even preserve the functioning of your insulin-producing cells and your sensitivity to insulin. Diabetes and dyslipidemia. So this is the other really big problem. So the interesting thing with diabetes and dyslipidemia is that this is actually the biggest criteria for heart disease. It's not so much your blood sugar control, it is the fact that the blood sugar itself causes accelerated atherosclerosis and deposits of these fatty substrates. So that's the actual thing that leads towards cardiovascular disease. So there's actually some interesting evidence out there showing that really strict glucose control is not the biggest factor for controlling heart disease in patients with diabetes, which is why your patients with diabetes really should be on lipid-lowering medications. Because independent of blood sugar control, we've got lipid problems going on because the whole metabolic pathway has been altered. So really it is the dyslipidemia that is the big underlying problem for heart disease. And what it is it's specifically hypertriglyceridemia, which is due to insulin resistance. And I have a little table on the next page that kind of shows some of this. So table 1 here just shows the mechanisms of diabetic dyslipidemia and how we get specifically to triglyceridemia. So you may remember that when we talk about our cholesterol levels, we tend to talk about LDL and HDL, and we tend to talk about our triglycerides as well. So LDL stands for low density lipoproteins, HDL stands for our high density. And these do very different things in the body, in that the high density tends to be a little bit protective, whereas the low density is associated with accelerated clogging of the arteries, atherosclerosis, et cetera. And so are triglycerides. So we want to keep triglycerides down, LDL down, and HDL up as much as possible. So we have increased glucose into the liver, and we've got hyperglycemia, perhaps due to insulin resistance in our type 2 diabetic type patient, beta cell dysfunction. And what it does is it stimulates the liver to overproduce triglycerides. So now we've got too many triglycerides in the liver as a result of our elevated blood sugars. We also have an increased amount of free fatty acids that are going to the liver. And we're going to, again, be overproducing our triglycerides. So you can see that as we go down through this kind of list, we have multiple things that are causing us to produce too many triglycerides and are contributing to atherosclerosis. All right, major complications of diabetes. Most of us are fairly familiar with the complications of diabetes. We have microvascular and we have macrovascular complications. Micro just simply means small, macro simply means big. So in the eye, in the kidney, and in the nerves, we're going to be damaging the cells in that area because, again, these specifically in the eye and in the nerves, these cells don't always need the transporters, the GLUT4 transporter, in order to bring sugar inside the cell. So they're getting bombarded and barraged by the high levels of serum blood glucose, and they don't have a good protective mechanism against it. The macrovascular complications are going to be things like our brain and our heart and our extremities, where now we're laying down lipid layer upon lipid layer, and we're actually blocking blood flow to those areas. We're causing inflammation. We're accelerating heart disease. We're accelerating risk of stroke because of these kind of macrovascular inflammatory processes that are going on. I'm only going to do one slide on each of the diabetes so that, again, we're going to be covering these in our subsequent case study presentations. Diabetes type 1 is basically you're not producing insulin. Diabetes type 2 is you are resistant to the insulin that you are producing first and may eventually stop producing insulin. But your initial mechanism is resistance. So diabetes type 1 is you're not producing. Your beta cells are starting to fail. They're just not doing their job. You have increased gluconeogenesis by the liver. What happens is you have high serum blood glucose levels, and you have intracellular starvation. So the cells are starving, but there's lots of food roaming around out there. This is essentially like living inside a house where you lock the doors and you refuse to let anyone bring you any groceries. You're just locked inside. There's a lot of food out there. You could have lots of friends standing at your door, banging on it, saying, hey, we've got food for you. And you're like, nope, stay out. Because they don't have the key, which is insulin. So you don't have that key, you can't get food inside the house. You have normal glucose handling prior to the onset of this. This is believed to be an autoimmune disorder and is often triggered by some sort of a precipitating event that causes destruction of the beta cells of the pancreas. And these people tend to respond very well to insulin, but again, keep in mind that if you have high levels of insulin over time, you will develop some measure of insulin resistance because the cells don't like it if you're jamming too much sugar inside the cells. Increased rate of birth defects occurs in diabetic patients who are poorly controlled. This is just a little picture of our beta cells, insulin-producing beta cells that are going out and releasing, and how they interact. What's happening is that you actually recognize markers on your own beta cells, and the dendritic cells and the T cells then work together to come back and specifically attack the pancreas. And this is what's happening with type 1 diabetes. Type 2 diabetes, insulin resistance, again, starts with insulin resistance, can progress towards failure to produce eventually. Risk factors. In general, this is over 30, although some of this is starting to shift at this point in time with the epidemic that we're seeing with greater and greater weight in younger children. So we're starting to see some kind of peculiar tip over of people developing diabetes mellitus at younger and younger ages because of the metabolic strain that's being imposed upon their body. Females tend to develop this more often than males. Associated with obesity, but not entirely. You can have people who are very thin, normal kind of body mass index, who could have type 2 insulin resistance diabetes. So essentially what's going on, we have too much insulin being produced over time, and the cells are going to essentially downregulate our receptors so that we don't bring as much sugar into the cell, which means that we have high levels of glucose out in the blood. And the cell is progressively less sensitive to our insulin. We do tend to have naturally increasing insulin resistance with age. The other mechanism underlying here is that sometimes the insulin itself can be a little bit altered in terms of its molecular structure, and therefore we can't respond to it as well. And that's all I'm going to say on diabetes for now. Gestational diabetes is essentially caused because we have increased energy requirements, high levels of estrogen, growth hormones. Growth hormones, anytime you increase growth hormone, you need additional energy production, which means additional insulin. So it's basically going to stimulate the overproduction of insulin again, and you're going to get a type 2 cellular response, decreased sensitivity to insulin over time. And essentially, this is just a insulin resistance type syndrome, which is why it's a marker for type 2 diabetes down the road.